I won't add any more to what Charlie elegantly described as our kind of underlying thesis for all of our healthcare work here at Restate, but I am very excited to be joined today by two excellent chief executives for us to talk a bit more about hospital reform. A lot of our framing thinking around hospitals, which is at times somewhat provocative in the health policy world, is that you can't achieve the shift towards prevention if you don't fix hospitals. And obviously, some people disagree with this because they believe that primary care, the shift towards prevention, it's that there should be more attention on other parts of the system. Hospitals already absorb so much of the money and resource in the healthcare system, so why should we be talking more about them? But it's precisely for that reason that we think we should be talking more about hospitals. You unlock more resource and capacity, and you make people healthier if you manage to improve them. Just fixing prevention and making the healthcare system more preventative won't organically fix problems in hospitals, which are systemic and operational. We outline a lot of this thinking in our Hospital of the Future papers, of which we've already published two, and we're publishing another in a couple of months. Generally, these papers consistently say that simply increasing funding or staffing in perpetuity will not fix the healthcare system, and it won't deliver effective healthcare. And like I say, for the most part, recent reforms have simply perpetuated a post-war episodic model when largely we're dealing with chronic conditions that don't go away once you've treated them. So there are severe problems facing hospitals in the short term, but these are underlined by profound systemic problems that will not go away if we manage to fix every other part of the healthcare system. So I'm looking forward to exploring some radical ideas as to how we do fix these systemic problems with Dr. Nnenna Osuji, who is the Chief Executive of University Hospitals Middlesex NHS Trust, and not Dr. Rich, sorry, I just promoted you to a doctor there, but now I'm going to have to rescind that. Richard Mitchell, he's the Chief Executive of University Hospitals Leicester and Northamptonshire. So we're going to make this quite an informal conversation. We're going to have a few questions I'm going to monopolise my chair privileges, and then I'll come out to the audience because I have absolutely no doubt that lots of people in this audience have lots of questions. So first, we recently published a paper called Hospitals as a Service, Not a Building, and it explored divorcing service provision from the physical hospital building. There were lots of different elements to this. A virtual first model was part of it, but there was also some thinking around funding and financial incentives. Generally, what do you both think the role of the physical hospital will be in an increasingly virtual first world?
So I suppose over many years, we have spent a lot of time on the terminology of out of hospital. But out of hospital is only one part of a solution. There will still always be a requirement for hospital. I think we need to think about what the modern acute hospital needs to look like with a changing demographic and changing demand. I think, for example, and I will take us to 2100. In the year 2100, someone born today will be 75. And their healthcare needs will be different. They'll be different for a number of reasons, and I think we've already outlined some of them. Many more multimorbid conditions, many more metabolic conditions. We think about the environment. Today is an incredibly hot day. Climate itself will create a different profile of diseases. At this minute in time, we have 1 in 5 people over the age of 65. By 2100, we'll have 1 in 3. And we'll have tripled the number of people over the age of 85. A very different demographic. That is going to be a demographic when they need acute care, when they need complex care, that will be in hospital. And whereas we may need fewer beds, the bed days they will occupy may be greater because their needs are more complex, more technical, more acute. So I think we need to think differently about what a modern acute hospital has to offer. At the same time, there's no doubt that unless we reduce the rising demand for health by prevention, and that prevention is not just about hospital to community. It's about community to individuals having a different contract around their well-being, making sure we're proactive. We will not reduce that rising demand that blocks the number of our beds currently. So I do see the need for an acute hospital for the future. It is a different hospital. It is a different model. It runs parallel to, not instead of, the need for prevention.
Can I just quickly jump in on that before you come in, Richard? And I'd love to hear your views on this too, Richard. What do you think about the discussion about bed numbers? It feels like this is a particularly blunt measure that's always used when we talk about hospitals. When we refer to other countries, people often compare it on bed occupancy and bed numbers. Our research on patient flow says actually the number of beds isn't the problem, it's how you get people in and out of them. What do you think about that? How would you review the success? What kind of metrics of success would you look for in a hospital that maybe isn't bed numbers?
Good question. So I think with everything we do, there's something about how we measure outcomes and how those outcomes impact people. So there's a question to me about, do we return people on discharge in a better state? And so there's something about the rehabilitation or dehabilitation that might happen that we might want to measure differently. I don't think bed numbers is the metric of choice. I think there's something about bed days and how long we occupy and how we compare that. So if we're all doing similar levels of intervention, and if we're all focused on the similar level of patient experience and outcome, the bed days for particular conditions might be a better benchmark for how we're doing. It also allows us to look at virtual models of care differently. How many bed days do we save by doing this?
Shall I come in? Good morning, everyone. It's lovely to be here. So I think this is a great conversation to be having at a really interesting time with the 10-year plan likely to be launched over the next week. I think I'm really proud to work in the NHS despite some of the challenges that we face. By and large, I'm very proud of the care that we provide. But I think one of the problems we face in the NHS when you compare us to international comparisons is the fact that the NHS is super fragmented. I was reflecting as you were speaking that in Leicester we work very closely with our healthcare partners and local authority partners, but from a governance perspective, general practice, community setting, urgent treatment centres, pharmacy, acute mental health providers are all provided by different organisations. And I think that can lead to disjointed care. I think it can lead to a lack of care, and I think it can lead to an over-reliance on an acute organisation. In Leicester, we're struggling with many challenges, two of which are the cost of care we're providing. We're an inefficient organisation, but also the volume of care we're providing. And I think we focus a lot on the efficiency factor, which is the cost of care. And I think collectively, as part of the 10-year plan, inevitably, whether it's through the focus on prevention or a greater focus on community provision, we need to focus on the volume of care. I agree. I think hospitals have a really important role to play, whether that's in 2125 or 2025 or 2100. I think the role of hospitals will change though, and we need to work far more closely with our partners. In terms of the volume of beds, I think it's a very blunt indicator of an organisation. Just so happens that on the way down to London, I was having an email conversation with our chief financial officer who said, we need to shut some beds to deliver our plan. And I was like, well, how are we going to do that? The number of beds we have open are based around the volume of patients that we're caring for and the length of stay. Inevitably, we have to take action to safely reduce the length of stay, identify patients who can be safely cared for elsewhere, whether that's post-hospital or rather than coming into hospital. But we also need to work more closely with partners to ensure that it's only the patients who need those beds who are coming into the acute organisation.
Yeah, I completely agree. I've got a lot of thoughts based off that, but I think one of the big ones I'm thinking, particularly around discharge, is we're seeing a lot of innovation increasingly around the discharge process because lots of people will point to it as being the big blocker for patient flowing through the system effectively. We've seen things like around ambient voice technologies in terms of, just taking away some of those operational frictions day to day that stop doctors from discharging patients effectively. What other kind of emerging technologies do you think could potentially really transform the NHS? Is there anything in particular in the hospital setting that you think, or you're already starting to see, is making quite a significant impact?
Shall I start? Yeah. So in Leicester, Northampton, and Kettering, we're trying to do do four things. We're trying to provide the best quality of care we can do to all. We're trying to be the best possible employer we can be. I think there's an intrinsic relationship between both of those things. We're focusing on working in partnership, whether it's with NHS organisations, local authority, general practice, community providers, and we're focusing on world-class research, innovation and education. The thing that binds all of that together is our use of tech, AI and digital. And whilst our working life can feel really difficult, the reason why I feel really hopeful and optimistic about the future is I think the evolving nature of AI and tech. And we think about doing things first, but actually, whether you look at other international health comparisons or you look at other industry, there's loads of stuff out there that we should be importing into the NHS. Very briefly, some of the stuff we're doing that I think is going to support our planned care agenda, diagnostics, cancer and emergency care. So across the East Midlands, we've got 8 acute providers. Within a matter of months, all 8 of them will be on the same electronic patient record system. UK-based provider that we have designed. It's clinically led, and what that will mean is if you're a patient in Leicester and you're transferred to Nottingham or to Lincoln or Derby or 4 other locations, the clinicians will be able to see your records. I think that's absolutely fantastic. If you are a doctor or a nurse and you're rotating between the organisations, you will be used to the platform. So I think that breeds huge amounts of efficiency. You referenced ambient AI. So in outpatients now, we've trialled it. We think it's good enough. We're rolling it out. Patients will be leaving their appointment within 2 to 3 minutes of their letter. Listening in, typed up automatically, they leave their letter. The letter goes to the GP. That improves efficiency. We're using the FDP to improve theatre utilisation. Theatre utilisation in Leicester was, I think it was in the bottom quartile last year. It's now upper decile as a result of FDP because we're booking patients with greater consistency. So I think tech can be used in a different range of different ways. Ultimately, all I think it can do is it means that you no longer have to provide that care. It means that you can provide that care in a different location, or it means that you can provide that care more efficiently. Inevitably, we focus on the third point. I think it's the first and the second point that will be a game changer.
I do strongly agree, but I want us to focus on people rather than processes. And I think a lot of the time we talk about interventions and innovations and we speak about processes. And without a doubt, there's a need for us to reduce duplication, make things more efficient, reduce time wasted so we can give more time to care. And ambient AI is a really good way of exemplifying that with all the right cautionary tales around that. I do not necessarily think discharge is where I focus. Actually, I'm much more interested in reducing attendance and reducing admission so that we only have the people who need to be in hospital. The reason for that is clear. We know that once you're admitted, particularly for some of our elderly patients, you're starting the last 1,000 days of your life. Why would that need to be in hospital? So my question would be, what is it we need to do with tech to make sure people feel empowered to not necessarily need hospital until they absolutely do? And I think the NHS app we know is increasingly important, but I don't know how many people are NHS app literate. Even in this room, let me just ask a question. How many of you have used the NHS app? Well done. For yourself versus an elderly relative. Brilliant. Lovely. It is a game changer. And actually, even when you go to a consultation, having that information available means you probably reduce the risk of another follow-up. So it's not just about innovation. Probably the innovation that we need is the innovation to do the basics right and to make sure we have spread of things that work well. Scan for Safety is another example of something that works incredibly well. We know that it would increase productivity, but the uptake of that across the NHS is poor. So where we have good evidence, there's an innovation and uptake that we probably need to look at. I will agree with Richard in terms of research, for example, and making sure that research applies to all populations so that we have outputs and impact that actually changes the dial. I think there's something about the volume of data we see. So whether it's personalized care and genomics or population and demographics, we don't have the headroom to really look at that data in the same way. So AI, large language models, are absolutely vital. They're not added value. And then the last bit for us is around diagnostics and the simple things that we do. I always ask the question, would you want your X-ray to be interpreted by a machine or by a human being? And it's really funny how people believe a human being would actually be better. our digital interpretation is 100 times better than any human interpretation. And there is something we need to do around making sure we use that in an educated and informed way. So I think that all of these simple things, before we get into the exciting and sexy elements, that we need to do better.
Yeah, I completely agree. To go back to your point, Richard, on integration, and obviously I think Nnenna alluded to this when you speak about reduced admissions, although integration probably isn't the best way of describing it, like you say, it's fragmentation with a desire to be integrated. Obviously, that was the entire premise for integrated care systems. And I think hospitals are kind of the constant embodiment of poor integration, because at the front door of the hospital, you have people that potentially could have been prevented at many other points in the system. And at the back door of the hospital, in order to get someone out the door, you often have to liaise with multiple local authorities, with a large multidisciplinary team. And you know, people often think about social care, but you also have to deal with problems of homelessness, uninhabitable accommodation, all sorts of different problems. What do you see as being some of are there any short-term answers to this integration puzzle, which seems to be constantly perplexing the NHS and particularly hospitals? And what do you think the kind of long-term view towards integrating the health system more effectively could be? I'm sorry, I realise that's a huge question.
So one of the things I've always wondered is why we've divided health into primary, secondary, and tertiary care. For a patient, it's care without boundaries, isn't it? And I think there's a reform in the way we think about it that's fundamental to looking at integration. What's best for a patient, and the discussion about who is accountable for a blood result and who takes it often dominates conversations that should be really about what's best for the patient and where can they get it. So I think there's something about us moving away from the artificiality of the silos in which we live and work. How do we do that in quick succession? Over to Richard.
Wonderful, thank you. I was going to say, I agree with everything you said. So going back to the point around fragmentation, if I've spoken to chief execs of healthcare providers outside the UK and I say, please help me, how would you do my job? And they say, well, I wouldn't do your job. I've got no interest in doing your job because it's far too fragmented. There's so much we do well in the NHS, and we should be proud, I think, of what the NHS and local authorities do. And we need to relentlessly focus on making things better. I think integrated care and integrated care systems and boards conceptually is great. I think so far the benefit, and I think they've just passed through their 3rd anniversary, I think that the benefits of them have been varied. So I think there's a lot of learning from the last 3 years. I think being an acute chief exec or provider of a chief exec provider is a difficult job. I think being a chief exec of an ICB is really difficult because you've got a lot of responsibility. You don't have a huge amount of accountability, and you haven't got the strings to pull because they deal with people like us who sometimes say, no, we're not going to do that. So I think we need to learn from the last 3 years. I think we need to jump on the 10-year plan, and like colleagues, I've read with interest some of the elements of it, and I feel quite excited by it. I think neighbourhoods is a real opportunity, but it's a risk. My interpretation of neighbourhoods is it could lead to sort of like hyper-localisation, and I think that comes at a huge cost, which is unaffordable at the moment for the reasons. So the way that I see through this, and I'm aware that it will be viewed as coming from the bias of being an acute chief exec, but I think we need much clearer governance of who is accountable for what. Last Monday, 970 patients received care at the Leicester Royal Infirmary. There was no emergency department, unfortunately, in the country that cared for more patients, 970 through a single front door. The team and I are accountable for those. At the moment, who's accountable for demand management? Loads of different people. And loads of different people is reliant on sort of a coalition of the willing or collaboration, and that's just not clear enough. So I think there's an emerging view that different neighbourhoods can be run by different organisations, certainly general practice in some parts of the country, local authorities, possibly, certainly community mental health providers. I think acutes have got a role to play. I personally think there's quite a strong body of evidence that when you integrate acute and community providers under a single governance, that means that you've got less boundaries, you've got a single cost base, you've got a single workforce, often you've got a single EPR. So I think there are real opportunities, but for me, I would start with the governance and who is accountable for the thing that you're trying to resolve.
I might just add a couple of things. We often talk about big players. We mustn't forget our voluntary care sector. And if I think back to the days of COVID and how much was achieved, and again, it comes back to neighborhoods and the players who are probably louder, better, trusted players in neighborhoods, and how we use them more effectively in an integrated way. So how do we get more conversation and more effective intervention from our voluntary care? I do think that many of our conversations are almost themselves dissected, because we're not looking at vertical integration as one thing and horizontal integration. We actually need something that combines the two. And then to the concept of neighborhood, just making sure we move away from geography as a defining feature, because there's so much more in terms of how people come together, how they convene. That might be a better lever to utilize for integrated type care. And I think those are some of the things that we can do today.
I'll just quickly jump on that as well, is that okay? So agree with that point around partnerships and looking to the voluntary sector and some of the local providers. So I'm the Chief Executive of University Hospitals of Leicester and University Hospitals of Northamptonshire. That's 3 statutory organisations. There is a benefit about us working together, but I think the much greater benefit is the way that we are working with our local providers in Leicester City. So if I think about my third of the 4 things we're focusing on partnerships, our partnerships with the Sharma Women's Centre, with the African Caribbean Centre, with the Somali mosques, with the Centre Project, with a range of local providers who are working with us to communicate and to engage effectively and listen to people in Leicester City. About 2 years ago, there was a concern about maternity services at the Leicester Royal Infirmary, and we took it very, very seriously. But what we wanted to do was to engage with the communities, plural, in Leicester City, so that they could feel confident that their local maternity services were safe. The Sharma Women's Centre, who represent women who come from South Asia countries, contacted us and said, we can engage with them more effectively than you can. They trust us in a way that they don't trust you at the moment. And I think the fact that they were proactively willing to engage with us and help us communicate and listen to people was a real sense of not only the partnerships working, but the sense of trust that we have built with we are building with our communities. So absolutely agree with the point.
That's really interesting. And kind of on the topic of patient communication and patient empowerment, obviously, as Charlie alluded to, this was a big theme in Jim Mackey's interview. And it is also a big theme in a potentially new proposed payment model for hospitals, which is that doctors, the medical workforce will be paid, well, not the medical workforce, sorry, the hospitals will be paid based on how satisfied patients are. And they will be rewarded or penalized for high or low patient satisfaction. What do you think about this kind of payment by performance model? Do you think that's the right metric? Do you agree with performance-based payments? Any immediate thoughts?
I think it's a good thing that we want to hear from patients and to respect their voice and their experience in deciding how we move forward. I think that's always a good thing. I think that there are many facets by which we do that at the minute, such as FFT, etc. Some of it is sort of complaints-based rather than affirmative-based feedback. I think it's difficult to have a monocular lens to feedback. I think you should always triangulate data to understand experience, because that experience needs to be contextualized. And I say that both in terms of the episode of acute care they may have, but in the context of the wider population that is served. At NorthMed, I have the privilege of looking after a population where 1 in 5 lives below the poverty line, where 100 different languages are spoken. Are you going to interpret the feedback that's given from that population? Are you going to use the right tools to get that feedback? Am I going to have a representative voice of that feedback? I also work in a hospital, and it's an integrated hospital now. We provide community care as well. But the reputational legacy is challenged. And so by definition, feedback tends to be negative. How do you correct for that and don't over penalize places where people are genuinely trying to move forward, but where reputation may hold back some of the feedback we get? I think it's quite complex, and I think we need to be careful about how we do listen to patients, but really, really mindful about how that's interpreted and utilized.
It's a great answer. Pleased you went first. So I think it's an interesting headline. Is it going to be the substance of the 10-year plan? Possibly not. I've worked at Guy's and St Thomas's, which you'll be able to see from some direction here. I've worked at Imperial College, Northwick Park, Leicester, and a couple of other organisations. And my learning is not all hospitals are created equally. And I'm nervous of any action that we take which will further, I think, strengthen the really strong providers and weaken the partners who are currently struggling. Like you were describing in North Middlesex University Hospitals, in Leicester, we're working really hard to make things better. I'm really proud of the care that we provide. Recently, one of our children has been an inpatient in Leicester. By and large, we get a lot of stuff right, but we don't always get things right. And there's a bit of a legacy there. There was a legacy that built up pre-COVID, and it was accelerated during COVID. We absolutely have to empower, engage with, listen to the people that we serve, whether that is our communities, the patients, the friends and relatives, and the people in our organisations. But I think a mechanism that will move money around based around people's interpretation of the care that they have recently received may not deliver the changes that we need to see.
That makes sense. And my final question before we open up to the audience is on the topic of the 10-year plan, if you could wave a magic wand, is there anything in particular you would want to come out of Thursday's plan for hospitals?
I should have checked before we started. What are the rules here around people being quoted?
I think it's, yeah.
They can be.
Quoted.
Oh, Christ. Have we got any journalists in the
No, I don't think so.
Excellent. Okay. Not that I can change any of my answers. I would just go back to, I'd say three things. One is the point around basics. There's some really exciting stuff happening, but we need to focus on the basics. I think a relentless focus on the basics and sharing of best practice gets us into a better place today and in 10 years' time. My second thing is I would like a recognition that integrated care is really important, but the way that it is currently being delivered is suboptimal. We are too fragmented, and we need to find ways, whether it's through governance or other opportunities, to work more closely together. And thirdly, maybe it's sort of contradictory to the point around the basics. I would like some stuff in there that gives people hope and belief and excitement, that because it is difficult at the moment. It's not all broken, but it is difficult. But gives people hope and excitement that the future will be better, because I think it will be.
Yeah, nice. Not too provocative as well. So hopefully, if someone does quote you, Nnenna.
I'm just going to say you asked him for one, he gave you three. Just noticed. I think it's a difficult question, isn't it? And I sit here and I think about how we actually move to start talking about outcomes and how we commission in that way. And that moves us away from counting things and looking at things in a shorter time frame. I think that's one of the ways that we move our conversation, our behaviors, our intent, and the way we build our systems into delivering something for the future. I don't know that that's something that will be delivered in 10 years. I don't know if that's something that will be in the 10-year plan. And the second element, because you had three, I'll have two, is something about facilitating spread. And I mean that in terms of, if we look at AI as a good example, there is a lot of excitement and there's a lot of caution. And there's a balance between the two to make sure we can move forward at a pace that allows us to deliver what is current, much less what is in the future. There is also something about us changing the rules by which we govern these things, because they're no longer tangible assets. These are concepts, and we need to think about them differently. So thinking about information governance and thinking about clinical governance when we're looking at concepts rather than things requires us to have a mind switch. I don't know how much of that will be necessarily enshrined.
Both great answers. Obviously, a profound shame neither of you said adopt every single recommendation the Restate has ever proposed.
We thought that was a given.
I thought it was coming. No worries. Anyway, opening up to questions from the audience. Of course, Adrian from the Royal College of Emergency Medicine, hand straight up. Could we get a microphone to him? It's just in the back row.
Thank you. So Adrian Ball, Royal College of Emergency Medicine. I just wonder whether we talk about the bed numbers, and I know it's a very blunt instrument, but at the same time, we also know that there's massive regional disparity in beds. We know that bed numbers per population head varies dramatically. East of England, Southeast Coast has less beds per head of population than perhaps major urban areas, and definitely less than Scotland. At the same time, we're in a situation where we're closing beds, and Simon hinted at this with all us, Richard hinted at this with all the problems in Leicester because of the SIP. At the same time, we are all seeing a dramatic increase in 12-hour stays in our departments. We also have a really centralized model where we have enormous, compared internationally, to enormous hospitals. I just want to focus in on this really on the last point about the about the size of our hospitals. Are they manageable? They're so huge compared to, you're talking about 970 patients attending Leicester Royal Infirmary in one day. That's in most other hospitals in the world, that would be a major incident which would be subject to EPPR, action after reviews. Are our hospitals too big?
Excellent question. That haunted me extensively when we were doing one of our hospital papers. So I'll let you guys answer it.
So thank you for the question. To be clear, I said there was a conversation about closing beds in Leicester, not that we are planning to, for the reasons that you will know, Adrian. Are our hospitals too big? I don't think so. I think they're too busy. Are they too big? I think it goes back to the way that you would run an organisation. So I'm the chief executive across Leicester, Northampton and Kettering. If we're saying Leicester's too big, people will be saying, what on earth are you doing working across the organisations? And that's something I'm thinking about at the moment as well. I think we need to have localised leadership. We need to have clear governance, use of information to understand what is going on. My job is not to understand the care that those 970 people are receiving. It's to ensure that we've got great local leaders and clinicians working together to provide that care. I certainly think the Leicester Royal Infirmary is too busy at the moment. And I agree with previous points in the conversation that I think the way of resolving that is not so much about focusing around the backdoor discharge, but it's about focusing on preemptive care, community-based care to ensure that the patients aren't coming into the organisation in the first place. So I think, I'm not sure if you were looking for a specific answer. My answer would be, I don't think our hospitals are too big. I think they're too busy. And I hope the 10-year plan gives us a way of de-escalating the pressure that all parts of the health system are under.
Do you want more questions or do you want a second?
No, we'll go finish this question, then we'll go out.
So I suppose the question is too big for what? So if it is too big for the demand of the people attending, then the answer is we still have people who are attending who are waiting in ED rather than in hospital beds. And so by definition, that answers that question. We are delivering care in the wrong place for the wrong patient. So there is something for us to do before we can even start to say what is the optimum size, because we have dealt with where people need to be best treated. So I think the question itself is possibly early and possibly contingent on how we deal with demand.
Great, thank you, Nnenna. So more questions. So to come to Kevin and this lady here in the black and white dress, and then this gentleman at the front as well. We'll do it in 3.
Thank you very much. Great conversation so far. I'm Kevin Fenton, President of the Faculty of Public Health and also the Public Health Director here for London. Hospitals have a critical role to play in prevention, whether delivering vaccination programs to your staff to prevent flu, COVID, or whether thinking about smoking cessation, brief alcohol intervention, well-being interventions, making every contact count. Is there a danger that as you move into this focus on the acute and the urgent, that your responsibilities of preventing health will be lost? And how are you managing that as leaders of hospital systems, which are critical in the prevention architecture?
Good question. Thank you, Kevin.
We'll come to you guys.
Oh, sorry, you wanted 3 questions?
Yes, sorry, Nnenna.
Question.
Could you just go to the lady in the black and white dress?
Thank you. Hiya, thanks. That's been super interesting. I'm Katie Abrahams and work on elective policy and reform in the Department for Health and Social Care. I just wanted to come back to your comment about demand management being absolutely critical for ensuring that we make sure admissions are, warranted. And I wanted to ask you what your view is about how we change patients' view of what a hospital delivers versus what the community can deliver, when we know that patients always, well, not always, but often want to see a specialist in hospital because that's where they believe they'll get better, more specialist care. I completely agree. It's around kind of accountability for demand management being spread and integrated across multiple partners, but actually, how do we change patients' view and their behaviour?
Great, thank you. And then final question from this gentleman at the front.
Thank you very much, Rosie. We spoke about the report, so I had a small part to play in it. Just hoping to slightly refocus the conversation. I'm Steve Layton, GP in St Albans. So we spoke at the beginning of the conference about how the needs of the population are changing, and they are, but slowly, because population ages and needs change quite slowly. However, population and people's preferences and the way citizens interact with services has changed dramatically over a very short amount of time. 20 years ago, I introduced telephone triage into the practice where I work in St Albans, and I had many struggles getting other GPs to speak to patients on the phone from an invention a few centuries ago. So where I'd like to focus the conversation a little bit more is on the way the citizen interacts with the service, which I think comes into the original introduction we had today. So there's a lot of talk about AI scribes for doctors. That seems to be the go-to technology that we talk about, and that's not a bad thing. But what about more about patients being able to input the things they want to talk about into the consultation prior to the conversation? What I use the NHS app, but really only for ordering my repeat prescriptions and nothing else. And the app should know how often I take my medication, and it should be updated. What about a technology I spoke to somebody about the other week about the patient's phone being able to listen into the consultation, and then they get a response. They get a summary of the consultation. What about advice and guidance and the patient being copied into the conversation between the clinicians, primary and secondary care? So I think unless we dramatically change the way the citizen interacts with the NHS, which I think is our way of getting to integration, I don't think we're going to achieve what we need to achieve. And I wonder if you could talk a little bit about how we bring about that fundamental change of citizen and NHS interaction. Thanks.
Thank you, Steve. Okay, Nnenna, did you want to come in with?
Now, of course, I have to remember all three
It's
questions.
right, I've written down.
Thank you. I'm glad.
Yeah.
So I'm going to start with the last question, if that's all right. And I think it is changing, and that change is generational. So the way my 19-year-old demands healthcare is different from the way I might demand healthcare. And that, by definition, will set the tone. I'm still practicing clinically, and I have patients who come in and they would have done Dr. Google or Dr. ChatGPT before they even get to me. It's a very different conversation, a much more informed conversation. But that's not every patient, and not every patient has the same level of agency. And this debate has always been live, but digital literacy will divide, but it will also allow us to have more time for people who are not digitally literate if we get the right populations engaging in different ways. I do agree with you, and I think there is power in our hands that we all use, but people's health-seeking behavior is informed by so many different things. And I always wonder about us trying to change patients. That's something that happens very gradually. That's something that happens through a societal mechanism or through a generational mechanism. And we do need to think about how we lean in on changes that are already existing, how we shout out when we've done well with a patient who didn't need to come into hospital. How do we use social media to say, I had great care at home, so glad I didn't need to come in. You know, we had someone who had children's hospital at home care, and when she spoke to our board about what that meant for her, it was powerful. I had other children at home. Very vulnerable time in my life. I want that conversation to be out there because those are the people who will change the minds of others. And just thinking about tech, we talk about tech as though health tech is unique. There are lots of other technologies which, if we lent into them, would help us in terms of health and well-being. And I think so much more to do, and we're not the only voices that need to be in that space. I use the word demand management because it's what we're all using colloquially. I'm actually much more interested in need. And if we separate demand and need, we'll have a much better conversation. At Northmid, we work with our GPs to have a GP front of house service. And we did that because whilst all the evidence suggests that we should be redirecting patients, actually patients are voting with their feet and they are coming. And so the question is, if they've come the first time, how do we make sure the next time they understand where they can go? And that comes back to, Kevin, your question, which is the responsibility of acute trust for secondary prevention, because we have a captive audience at a time when they're probably more receptive because of their vulnerability. So I do think that responsibility will still stay. I think there's a second bit, which is the anchor responsibility of organizations, and that comes to employment, that comes to climate sustainability, and that comes to the fact that whilst we can talk about our staff as staff, 50% of our staff are actually local residents. So we are actually starting the conversation with our staff. And I do think secondary prevention is an absolute responsibility of every acute trust.
Great, thank you, Richard.
So I agree with the points. I think secondary care has a key role to play in partnership with others from a prevention agenda, whether that is, as you described, Kevin, the work that we do with our colleagues in the organisation, or the work that we do with our with the people that we serve. And you make a great point that often they're the similar people. I think we have to be realistic that we face a whole range of competing priorities. It's not a binary choice, but we do need to prioritize. But I think the only way which we will make the longer term better than the recent past is secondary care, primary care, others working truly together on that agenda. And I think there are many examples across the country and internationally where that has been a huge success. I think that the second point around changing people's opinions of what hospitals are for, the only point I would build on is, I think people listen to clinical colleagues, listen to general practitioners, they will listen to community leaders. And me stepping into Leicester City and trying to convince people that the hospital is changing and you no longer need to be reliant on your local hospital in the way that you have been is unlikely to be successful. Me working in partnership with general practice, Sharma Women's Centre, African Caribbean Centre, etc., and communicating effectively with people that they know and trust, and we personalise it with stories where people who have previously accessed care in this location and are now accessing care somewhere else, I think is really powerful. And then just the final point I would add to it is, I was last week listening to a GP talk about the digital infrastructure that he has in his practice, and it's way better than the stuff that we're doing at the moment. There's much greater agility in general practice, and as you described, there's things that you were doing 10 years ago that we're only beginning to do. And he made the point, I think was one that you were making, about they've now got sort of an automated triage tool, and as part of that, it populates, these are the questions that I want answered in my 10 or 15 minutes with the GP. And I thought that was such a simple but a brilliant thing, as opposed to going into an outpatient appointment. You've got a narrow window and trying to get everything. So I think there's great opportunities to learn together on that. My final point was going to be, if there's any doubt as an acute chief exec that I've been communicating a message of let's deheat an acute organisation and put more pressure elsewhere, absolutely not. We all recognise that general practice is under pressure, community mental health providers, local authorities under huge pressure at the moment. So it's easier said than done, but I think it's doing things differently as opposed to transferring risk and volumes of patients out of an organisation somewhere else.
Great, thank you. And I think we've got round for a quick round of questions if there's any more, but yeah, one more at the gentleman at the back, and then if there's time, I might continue to abuse my chair privileges. Oh no, there's another one, so I can't. That's fine.
Hi, Nick Hicks, old a public health doctor, but recently seconded into the department to a system strategy unit from the University of Oxford. There's been a lot of talk about integration, about outcomes, about governance. I was just thinking, what would happen? How would you welcome somebody saying that you and your organisation should be judged not just by the quality of the care you offer to the individuals referred to you, but for the outcomes of your population? what would happen if the identity of your clinicians changed? So when you said, who do you work for? In my patch, if I talked to one of my colleagues, he'd probably say, well, I work for the Oxford University Hospitals Trust Diabetes Service. What would it take to get them to say, I work for the Oxfordshire Diabetes Service and I'm judged on the outcomes of the population as well as the individuals I look after, bringing prevention then into their remit? And also thinking about the shifts of the
I'm so sorry. I think I might just have to move on to the next question just because we've got okay. It was just the gentleman on the right. Sorry.
I'm going to come with a slightly different perspective. John Ralling's County Councils Network. I've recognised and really appreciate Richard particularly pointing out the pressure local authorities are under. Can I just throw a bomb in there and say that one of the real barriers to integration is A, we're not getting a 10-year plan for social care at the same time, and B, CCN conducted the first study from a local authority perspective into the development of ICBs. And what we found was there was an awful lot of optimism from in local authorities about being able to do it. But the way things are set up at the moment, we are very much junior partners, often powerless. You have situations where you have in the Northeast about 13 local authorities trying to engage with one ICS. Then you have situations in Essex where you've got 3 ICS footprints on the local authority. So can I ask you as well, because I know for a fact, it's interesting, you're both saying you wouldn't prioritise discharge. Is that because you know that the pickup is going to be that the local authorities get blamed for that, even though we found 50% of patients should be on pathway 0, but you know where the media narrative goes? So I'm just sort of saying, how do you think we can fix that? Because ultimately we want local authorities involved. We want to be working with our health partners, but at the moment we feel there's so many barriers to that.
Okay, quick fire answers.
Can hear that, can respect that. The priority is not only on attendance and admissions, it's also on discharge. But if I had to choose one, it's to prevent the need for discharge in the first place. So it is both. Absolutely respect that. I think there is something about what's in the plan and what will be done, which will overlap, but not necessarily be a complete overlapping Venn diagram. We need to get on and continue to work with partners, and local authorities are absolutely critical to all that we do. Absolutely agree that if we can change identity of who we work for, that's going to take time. We should start by employing people within those systems rather than necessarily in organizations. The model by which we do that doesn't yet exist. Maybe that's something for us to look at.
Super briefly, so in answer to the first point, I think there's some people already thinking and talking about that. If I think about the diabetes service in Leicester, they would use the language that you have used. And then in answer to the second question, I think in most ICBs, or certainly in some ICBs, local authorities do feel like the junior partner. I work across 2 ICBs. One of them, they're certainly the junior partner. The other, they're being engaged with far more effectively. And that was my point about learning from over the last 3 years and making sure that we work more effectively. It can't just be a vehicle for delivering the NHS agenda. It has to be a vehicle for delivering the NHS and care agenda. I agree with your point about the need for a 10-year plan beyond the NHS.
Great, thank you. I hope everybody enjoyed the panel and learned a lot. I know I did. So if we could thank our panelists, and then we'll move on to the next panel expansion.